Hi everyone, welcome to our Dental Hygiene Board review. For perio, let's get started with inflammation and tissue repair. Inflammation presents with 5 cardinal signs: redness, heat, pain, swelling, and loss of function. It's important to remember these signs, as they are fundamental to understanding inflammation. Moving on, let's talk about hypertrophy and hyperplasia. Hypertrophy refers to an increase in cell size, while hyperplasia is an increase in the number of cells. Atrophy, on the other hand, is a decrease in the size and number of cells. Metaplasia occurs when an adult cell changes to a different cell type, which is significant in various disease processes. Understanding these changes helps us better grasp how tissues respond to different stimuli. Acute inflammation is an immediate or early response that doesn't last long, characterized by the presence of polymorphonuclear leukocytes, also known as PMNs, in the first 6 to 24 hours, followed by monocytes. Chronic inflammation, in contrast, is a response to persistent infection and lasts for weeks, months, or even years, involving macrophages, lymphocytes, and plasma cells that make antibodies. Recognizing the difference between acute and chronic inflammation is crucial for diagnosis and treatment. Now, let's delve into the microscopic events in inflammation. The sequence of events includes brief vasoconstriction of small vessels, followed by vasodilation within seconds, leading to hyperemia due to increased blood flow. This is followed by increased vascular permeability, transudate leaking into tissues, increased blood viscosity, and decreased blood flow. Margination and pavementing occur as white blood cells move to the vessel wall, leading to emigration of these cells into the tissues. Exudate then enters the tissues, causing edema, and phagocytosis occurs in the injured tissue to clean everything up. This sequence helps us understand the body's response to injury or infection. When discussing clinical features versus microscopic events, redness or erythema is due to hyperemia from vasodilation, while heat is also due to hyperemia. Swelling, or edema, results from exudate in the tissue, and pain or dolor is from kinins and prostaglandins in the area. Loss of function results from edema, pain, and swelling. Fever is caused by prostaglandins and cytokines in response to pyrogens from white blood cells and microbes. These correlations are essential for diagnosing and managing inflammatory conditions. Next, we'll talk about soft tissue healing. After periodontal debridement, healing occurs in stages. The junctional epithelium, also known as JE, heals within 5 to 7 days as an elongated epithelial attachment. Connective tissue heals slowly within 1 to 4 months. This is why probing is avoided for 4 weeks post-debridement to prevent damage to the healing connective tissue. Understanding the healing timeline helps in planning follow-up care and interventions. Now, let's discuss healthy gingiva, periodontal ligament fibers, and bone. Healthy gingiva should be smooth and intact with no ret pegs, and a sulcus depth of 1 to 3 millimeters. The periodontal ligament fibers attach the tooth to the alveolar bone, with different fiber types, such as apical, interradicular, oblique, horizontal, and alveolar crest fibers, serving various supportive functions. Knowing the structure and function of these fibers helps in understanding periodontal stability and health. Speaking of the alveolar process, it includes the lamina dura and cancellous bone, containing the tooth sockets or alveoli. A dehiscence is a resorbed area of bone over a facial root surface, while a fenestration is an opening in the bone on the facial surface of the root. The biologic width is the 1 to 2 millimeters of connective tissue attachment covered with epithelium between the probing depth and alveolar bone. Understanding these structures helps in identifying and treating periodontal issues. When it comes to bone loss from periodontal disease, it results in osseous defects like suprabony and infrabony pockets. A suprabony pocket has the base of the sulcus coronal to the alveolar crest, while an infrabony pocket has the base apical to the alveolar crest. Recognizing these defects is crucial for appropriate periodontal therapy. The host response plays a significant role in periodontal disease development. Tissue destruction seen in periodontal disease results primarily from the host response, which varies widely among individuals based on their response to microbes. Blood supply to the periodontium comes from the inferior alveolar artery for the mandible and the superior alveolar artery for the maxilla. Sensory innervation to the periodontal ligament and bone of both the mandible and maxilla comes from the trigeminal nerve. Periodontal assessment includes collecting probing depths, measuring clinical attachment loss, checking for bleeding on probing and suppuration, furcations, and assessing pathologic mobility and migration. Probing and measuring clinical attachment loss help assess disease progression and remission. Let's now move on to microbes, plaque, and calculus, which is a significant part of periodontal disease. Dental plaque is the major etiologic factor in the initiation and progression of periodontal diseases. It adheres strongly to teeth and oral structures, consisting primarily of bacteria. Gram-positive microbes are aerobic and non-motile, while gram-negative microbes are anaerobic and can be motile, with lipopolysaccharide endotoxins contributing to tissue destruction. In gingival health, the microbial flora includes streptococci. Gingivitis involves actinomyces and Prevotella intermedia, while chronic periodontitis involves Porphyromonas gingivalis. Localized aggressive periodontitis, also known as LAP, involves Actinobacillus actinomycetum comitans, or AA, and necrotizing ulcerative S. Gingivitis and necrotizing ulcerative periodontitis involve Spirochetes and fusiform bacilli. Plaque development includes pellicle formation, initial bacterial colonization, and bacterial growth and maturation. Supragingival plaque biofilm forms above the gingival margin, while subgingival plaque biofilm forms within the gingival sulcus and is initiated by supragingival plaque. This development is key to understanding how plaque contributes to periodontal disease. Calculus formation doesn't directly cause periodontal disease, but contributes by providing sheltered areas for plaque to be close to the tissues. Calculus is formed by the deposition of calcium and phosphate salts within the plaque. The rate of calcification or mineralization varies greatly, with the onset occurring in 4 hours to 14 days. The presence of saliva, calcium, and phosphorus increases the rate of mineralization. Supragingival calculus, also known as salivary calculus, forms above the gingival margin and can be yellowish-white, while subgingival calculus, or ceremal calculus, forms below the gingival margin and can be black or dark green. Moving on to gingivitis and periodontitis, these conditions are primary concerns in periodontal disease. Gingivitis is the inflammation of the gingival tissues and is the most common human disease. There are 4 stages of gingivitis development: initial, early, established, and advanced. Periodontitis, on the other hand, is the inflammation of the attachment apparatus, which includes the periodontal ligament, cementum, and alveolar bone. Periodontitis involves the migration of the junctional epithelium apically and bone loss that begins in the crestal bone. The pathogenesis of periodontitis involves the thickening of the circular epithelium and the formation of rete pegs. Tissue destruction is primarily due to an antigen-antibody immune reaction, with bone resorption caused by lymphokines, prostaglandins, and activated complement. Chronic periodontitis is the most common form of periodontal disease, characterized by clinical attachment loss, slowly progressive bone resorption, and primarily horizontal bone loss. The severity of chronic periodontitis is directly related to plaque and calculus accumulation. Treatment for chronic periodontitis includes removing local etiologic factors, such as plaque and calculus, providing patient education for personal plaque control, and performing periodontal surgery if needed. Root planing removes endotoxins from cementum and disrupts plaque biofilm. Aggressive periodontitis includes conditions like prepubertal periodontitis, localized aggressive periodontitis, LAP, generalized aggressive periodontitis, GAP, rapidly progressive periodontitis, and refractory periodontitis. Each type has specific characteristics and requires targeted treatment approaches. Periodontal abscesses include gingival abscesses, acute periodontal abscesses, chronic periodontal abscesses, and pericoronal abscesses. These conditions present with various symptoms such as pain, swelling, and purulent exudate, and require specific treatments like debridement, surgical curettage, and systemic antibiotics. Occlusal trauma can be primary, involving heavy occlusal forces on a normal periodontium, or secondary, involving normal occlusal forces on a compromised periodontium. Traumatic occlusion can increase clinical attachment loss and bone destruction in the presence of inflammation. As we approach the end of this section, remember that understanding the fundamentals of periodontal disease, including inflammation, tissue repair, microbial factors, and treatment options, is crucial for effective diagnosis and management. We'll continue with periodontal surgeries, sutures, and dressings in the next part of our review. Thank you for listening, and stay tuned for more detailed information on these topics.